And now I want to introduce our first speaker, Dr. Anthony Bailey. Dr. Bailey became professor and chair of child and adolescent psychiatry at UBC in July 2010. He came from the University of Oxford, where he was the Cheryl and Reese Scott Chair of Psychiatry, the first medical chair devoted to the study of autism. Dr. Bailey's research has investigated the neurobiological basis of autistic disorders using genetic, neuropathological, and neuroimaging approaches. His clinical work focuses on teenagers and able adults with autism spectrum disorder. Please welcome Dr. Bailey.
Thank you, Dr. Weir, and thank you also for one of the clearest introductions to a conference I've ever heard. No one's in any doubt about what you have to or not do. I'm in the wrong time zone, so I completed the quiz at about 5 o'clock this morning and got very anxious because there were a couple of questions where I thought, I'm not sure what I'm meant to answer here. Am I meant to answer what people believe or what is true? So it'll be interesting to see what the correct answers to the quiz are. I've also seen many different variants of what I'm meant to be talking about today. So in various publications, I'm covering something different. So I thought I'd tell you, after I've revealed that I have a disclosure to make, which I don't think requires any mitigation. This is really what I'm going to be talking about. So I wanted to give some very basic background about ASD, explain how the diagnostic schema that is still in place in ICD-10 came about, and probably spend all of 1 minute on DSM-5, and then go on to spending most of the time talking about how you might pick up adults with ASD who have reached adult life without a diagnosis. And then I'm going to do a very brief overview of what I see as important management issues, which will be elaborated upon by all the subsequent speakers. So many years ago, I was taught that autism had a prevalence of 2 in 10,000, and if I became a GP, I would see 2 people with ASD in my lifetime. And as most of you know, over the last 15 years, there's been a very dramatic rise in the detected prevalence of ASD. British Columbia has had in place a relatively uniform diagnostic scheme for the last 7 years, and that relates to the fact that parents are provided with a sum of money, as is the schooling system, to provide extra help for people with ASD. And in order to qualify for that money, their child has to have a diagnosis where the ADI and ADOS were used. These are the 2 gold standard diagnostic instruments. There's no requirement that the child has to meet any particular threshold on those instruments. So this is the data collected in BC since 2007. And as I say, the diagnostic approach hasn't changed over that time. So the rate last year was 1 in 76. So 1% of the population I use as a rough approximation, and this graph isn't showing any signs of leveling out at the moment. If we go back in time, it's clear that the bulk of the increase in diagnosis comes about from recognition of people with an IQ in the normal range, as well as some diagnostic substitution for people who in the past had a diagnosis only of mental retardation and not of ASD. And in the early 2000s, Eric von Bonn and Dr. Chakrabarty published an interesting study in Staffordshire in England, where they found that in a total population of children aged under 6, it was children with PDD-NOS who represented the vast majority of children. So we believe that a lot of this increase is simply down to better detection of less severely affected individuals than those, particularly those with an IQ in the normal range. Across the IQ range, males are more frequently affected than females. There have been some studies suggesting that if one focuses just on individuals with Asperger's syndrome, that the male excess could be as high as 8-to-1 up to 15-to-1. Now, it's unusual for medical disorders to change their sex ratio as one goes across the severity spectrum, and I think most professionals believe nowadays that these changes in sex ratio reflect the fact that we're not very good at identifying women with Asperger's syndrome. And I suspect some of the subsequent speakers will pick up on that as well. There have not been systematic studies of ASD prevalence worldwide, but as far as we know, it occurs in all cultures. There's no evidence to date of huge variations between countries. My impression since being in Canada, and it is only an impression gained from talking to colleagues, is that there is a lower prevalence of ASD amongst the First Nations communities, and it's unclear to me whether that in fact reflects a genuinely lower prevalence or reflects differences in diagnostic patterns or referral patterns. Most individuals with ASD develop ASD because they've inherited a complex mix of susceptibility genes, and sometimes we can see milder autism traits in relatives, and of course it's not unusual for the occasional relative, not necessarily in the nuclear family, also to have an ASD diagnosis. The commonly identified non-complex genetic causes of autism are Fragile X syndrome, probably accounts for about 2% of people with autism, tuberous sclerosis, another 2%, but in both cases these causes predominantly in people with intellectual disability, and autism is associated with a very wide range of chromosomal abnormalities, and as you all know, living in Toronto, CMVs, copy number variants, play an important role in etiology, but probably act in the same way as other genes contributing to a complex mix. Historically, we used to think that most people with ASD had an IQ below 70, and we now think it's the other way round. And in terms of the underlying pathology, the vast majority of evidence suggests that autism has a prenatal onset. The relatively small number of post-mortem studies all find abnormalities in cell migration or cell type that reflect differences during development. Unlike mental retardation, the association with ASD is with increased head circumference rather than decreased head circumference. There's lots of evidence for abnormal connectivity in the brain, and we've known for a very long time, and Dr. Psych was key in this, that EEG abnormalities and epilepsy have a strong association, particularly with more severe autism. One of the questions was about the rate of epilepsy in autism, and this is one I thought might have been a trick question. So if you take a population of people with so-called classic autism or infantile autism, there are many studies finding that about 25% of those individuals, and that's a very broad confidence interval around that 25%, will develop epilepsy. Some people early in childhood and others in adolescence or early adult life. If one moves to people with Asperger's syndrome or more able individuals on the autistic spectrum, the association with epilepsy is much, much weaker. And the vast majority of my patients do not have epilepsy. But to my knowledge, there hasn't been a recent study estimating what the rate of epilepsy is in that population. But my guess is it's elevated above the population base rate, but substantially lower than that in individuals with clear autism. We know that from a cognitive perspective, people with ASD have many different types of cognitive impairment. Over the years, different groups have tried to argue that their favorite cognitive impairment was the central cause of autism and everything else was a secondary consequence. We've sort of shifted to the more realistic view now that in a complex disorder that affects many aspects of brain functioning, that there are impairments in all of these areas and others. And what this means is that people end up with impaired understanding of social situations and the meaning of language, that they're also impaired in generating social behavior and language that is appropriate for context. Not part of the diagnostic criteria is that many individuals will have difficulties with self-control, particularly in childhood or adolescence. And the rigidity associated with autism impacts on people's ability to be flexible, to take advice, to fit in with other people, and can cause a lot of day-to-day impairment. And I've no doubt that you'll hear repeatedly today about anxiety. Not everyone with autism runs an unusually high level of anxiety, but the majority of people do. And when I'm not diagnosing, I'm managing anxiety. Sometimes comorbid with depression, but nearly always anxiety. And there's a sort of toxic mix between anxiety and other mental health disorders and people's lack of goals and low self-esteem. So the typical patient that I see will be their early to mid 20s, might have not done too badly at high school. They leave high school, things start to fall apart, their mood drops, they don't have a clear plan for what they're going to do with their lives because they're anxious, they don't leave the home. Typically they'll be glued to the Xbox and have repetitive strain injury of their thumbs, and they are really stuck. And of course, once you get stuck, your mood drops, and that would be a typical situation for most of these people. So one of the things we have to think about as clinicians is how we undo all of that and generate a bit of momentum again in people's lives. So why are you having a conference today about adults with autism? Well, I think the main reason is because the prevalence in children has shot up, and therefore people are much more aware now of ASD than they used to be. The penny has slowly dropped, that this large cohort of people are soon going to enter adult life. We realise that if you have a diagnosis, that enables professionals and family members to put in place supports and guide you in a way that will maximise your quality of life. But we've also realised that we are seeing more and more people at the milder end of the autism spectrum who are not getting a diagnosis until adult life. And usually the route to diagnosis is going to your GP with another mental health disorder, then seeing a psychiatrist. The smart ones will realise there's ASD. An exceptionally tiny proportion of those people will be comfortable making a diagnosis and going ahead. But at the moment, I think for many adult psychiatrists, ASD is just on the borderline of their comfort zone, and many people would prefer that a so-called expert confirmed the diagnosis. So we have a group of people who are getting a diagnosis of a lifelong disorder relatively late in development. As I pointed out earlier, women are particularly underdiagnosed, and most years I will see a mother who's had a child or two with autism and then quite rightly asks, has she got the same or related disorder? Throughout the world, there are very few services for able adults with ASD. In the UK, historically, if you had an IQ below 70, you had a consultant in learning disability attached to you, first in childhood and then a separate person when you reached adult life. So there was a clinician who had oversight of your care from cradle to grave, and no such situation arose for people with Asperger's syndrome, so the learning disability services would deny they had any legal responsibility, and mental health would say it was not our problem, we don't know anything about this. The UK introduced some legislation a couple of years ago that was meant to close that loophole, and I'm sure Jane can tell us later how much smaller, if at all, the loophole has got. And the focus today on comorbid disorders is very important, both because this is usually the way that patients present, but also if we don't manage the comorbid disorders, it's hard to move people along. But if we don't move people along, we don't cure the comorbid disorders by and large. So we're really thinking about two quite different groups of individuals. We have individuals who reach adult life with a diagnosis, many of whom will have an IQ below 70, and I'm not going to be discussing that group of people today. Then we have able people who reach adult life with a diagnosis, and the group I'm particularly interested in, the able individuals who reach adult life without a diagnosis, but often present with mental health issues, and they're of both sexes. Why do they get to adult life without a diagnosis? Well, very often people have not shown any of the more severe hallmarks of autism that the man in the street is used to associating with a diagnosis. So I trained with Michael Rutter, who is, when in one of his rare humorous moods, would say that the refuse collector could have diagnosed this child, and why were we all gathered there? So we have in our mind, most people have in our mind, a very clear idea of what someone with severe autism looks like. But able individuals will usually muddle through school because there's strong structure. Things might start to go wrong in adolescence when the social environment changes mightily. But also they have mothers. And mothers are a hugely underrated support to people with ASD. And often the lack of a mother becomes clear when people move into higher education or into a job, and where the mother doesn't have the capacity to organise assignments, send people off to school with their bag with the relevant things, check that everything's been done. So really what we're seeing is the weaknesses revealing themselves in a more complex environment socially, and as supports that have been present in childhood disappear. Probably the most common misdiagnosis of autism is ADHD. Now, misdiagnosis isn't really the correct term, because many individuals with ASD do indeed have ADHD, but they also have ASD. And the usual explanation for this is that parents go to clinicians complaining mainly of the child's inattentiveness and overactivity. And if the clinician doesn't take a comprehensive history, then it's possible to miss the fact that the ADHD is in the context of ASD. These are very expensive disorders. So this data comes from Martin Knapp's update of a study he first carried out in the UK in the early 2000s. He's extended it now to include the US. I'm giving these costs because we don't have costs for Canada that I'm aware of. So you can see that adults account for the vast majority of costs of these disorders. Of course, that's understandable because a large proportion of the cost is providing lifetime care for a more handicapped group of individuals. But 45% of the costs are from lost employment, and that comes from a combination of having to make some sort of disability payment to the individual and lack of income tax receipts. And that's why many clinicians who specialize in ASD in adult life put a lot of emphasis on getting people into employment, partly because it's saving the country money, but it's also probably the pivotal mechanism for improving people's self-esteem and improving mood. Now, the ICD-10 system is about to be replaced by a diagnostic schema that will look essentially identical to DSM-5. But at the moment, you have two diagnostic systems, and I just really want to explain how we've got to where we are. So Leo Kanner first described autism in 1943, and really what he described was a group of very handicapped children with so-called classic autism. 1 year later, Hans Asperger wrote a paper in which he described a group of children who were referred to him after they'd started school, usually for conduct problems. And that took one of two forms. Either they were not getting on with other children, sometimes bullying them or insisting on them playing things in particular ways, or they weren't compliant with teachers' requests because they thought their way of doing maths or their facts about the stars were more correct than those of the teachers. And Kanner and Asperger both appreciated that they saw milder traits in some relatives of people with ASD. Subsequently, Kanner interpreted this in one particular way, but Asperger was pretty clear that he thought that this was a genetic disorder than that it was passed from father to son, because he thought these traits were more evident in fathers than in mothers. Asperger's account was written in German, end of the Second World War, and really didn't become widely known until Jutta Frith translated it into English in 1981. So Asperger's syndrome appeared relatively late in the ICD and DSM criteria. And so what happened after Kanner's definition of autism was that clinicians started to see some individuals who looked as though they had Kanner's autism but didn't seem to be severely affected enough in one domain, or the age of onset seemed later than they would expect. So the term atypical autism was coined. And then many years later, clinicians realized that they were seeing many more children who looked as though they had impairments in all three areas of functioning, but nowhere near the level of severity first described by Kanner. And this gave rise to the term pervasive developmental disorder not otherwise specified. And certainly in the UK, parents hated this label. And of course, it turned out to be completely true, because not otherwise specified means you're the leftover category. But as I pointed out earlier, Eric von Bonn, in his very careful study, discovered, in fact, they were the main category. And Rett syndrome and disintegrative psychosis were thrown into this group for understandable reasons. So the ICD-10 scheme has arisen through largely historical accident. And I am still going to stick to going through the ICD-10 scheme, because although I applaud the simplicity of DSM-5, if you're not very familiar with autism, it actually doesn't describe it terribly well. So it's been a retrogressive step. So if you want to learn about autism, I suggest you have both books at hand. And if you really want to learn about autism, I'd read the ADI, because that's the sort of potted summary of what autism looks like. DSM has collapsed 3 domains into 2, but essentially that is an administrative collapsing. It's not that any of the symptoms have disappeared. So a very common way in which we recognize autism in individuals is people not using appropriately non-verbal behaviors to regulate social interaction. This is one of the standout features, and by that I mean not using eye contact to regulate social interaction, which is different from whether you look at someone or not. It's using eye contact to signify intention, using facial expression to indicate what you're thinking or feeling, or indeed understanding its significance in other people, using gestures, either descriptive gestures to elaborate on what one's saying, or emphatic gestures. If I wasn't holding this, my hands would be going all the time. I must have some Italian genes in me somewhere. And we also think about non-verbal behaviours in terms of body posture, how we convey how we're thinking or feeling, or indeed our proximity to other people. We're all very used to people with ASD standing too close to us, and that's an obvious abnormality. But if people are talking to you and actually they stand just slightly too far away, that immediately feels incorrect. The ICD-10 criteria were written a long time ago, when our idea of ASD was much more at the severe end of the spectrum, and hence failure to develop peer relationships. We know that that's not true for the majority of people on the spectrum, that able individuals will develop peer relationships and subsequently friendships, but often not until much later in life than typically developing people. They may not have the same rich quality to the relationship. It may hinge around a special interest. And romantic relationships tend to be very difficult for the vast majority of people with ASD. Lack of shared enjoyment is referring to the difficulty that individuals have in picking up on other people's emotions and responding appropriately to them, hence the lack of reciprocity. Now, in DSM-5, the social and language, or social and communication domains, have been collapsed together, which has some advantages, because the diagnostic abnormalities are to do with the social use of language. The disadvantage is it downplays to some extent the impact of having a language disorder on everyday functioning. And we've known since autism was first described that the best predictor of long-term outcome is language ability and IQ. So historically, we thought that about half of children with autism would never acquire any useful speech. Obviously, that percentage has dropped dramatically as the spectrum has expanded. But those individuals will not use other means to communicate. So they're not signing spontaneously in the way that deaf children will. And even if you provide them with some means of functional communication, some electronic gadget, children will find that harder to use. Interestingly, I've seen lots of older teenagers and young adults with very limited language skills make very good use of various iPad apps that will, if they're able to type in, will speak for them. And I think there's plenty of room for us to develop applications that will overcome some of the communication impairments in ASD. For historical reasons, play was put in the communication domain because it was thought that it was important that you had inner language in order to be able to generate a complex symbolic play scenario. But the two aspects of autism that have transferred in DSM into the social domain and that are most relevant to us are to do with using language for social interchange and idiosyncratic aspects of language. So people with ASD find it hard both to have conversations and to chat. Equally, many people will produce more stereotyped speech than is typical for most of us. We all have some stereotyped speech. We fall back on it sometimes when we're talking to patients or lecturing our kids, or when we've had a drink too many, pretending to be an expert in something that we're not really an expert about at all. But for most of us, our stereotyped speech tends to occur in very particular situations. Children with autism will often have a lot of stereotyped speech when they are very small, and that can be a key diagnostic feature. If they're going to acquire more useful language, what usually happens is that the stereotyped speech becomes increasingly absorbed into generative language and used more appropriately. But stereotyped speech, in my experience, usually doesn't go away completely and will often be more apparent when individuals are stressed, perhaps at a diagnostic interview, and is a key diagnostic feature. And then our third domain has been retained in DSM-5. So typically in able individuals, what we might find are circumscribed interests as opposed to unusual preoccupations. So a circumscribed interest is an interest that would be normative for the population. In other words, it's not unusual, but the intensity of the interest is unusual. So the person might engage in it all the time or talk about it all the time, to the extent that it interferes with theirs or family life. Then people can be very routinized or ritualized and find change difficult. In young children, we're used to seeing motor mannerisms that are very useful diagnostic sign. We're also used to seeing those decrease as individuals get older, but they don't always go away completely, and the fact that you don't see them doesn't mean they don't happen, because many able individuals learn that it causes you a bit of social difficulty if you flap or engage in hand and finger mannerisms in class or in public, and therefore suppress them outside the home, but might well engage in lots of motor mannerisms at home or in their own bedroom. So it's helpful to inquire about that. And people will tell you if they spin or do other things. And the preoccupation with part objects or non-functional elements, so here we're talking about lining things up, spinning things, dropping things, repeatedly moving things from one area to another. By and large, characteristics that occur fairly early in development, and if they persist, it's usually in more handicapped individuals. Now, people don't come to you having filled in that little checklist. They usually come complaining of depression and anxiety, or they're brought by their parents, sometimes after a big struggle. And the parents might complain that the person is socially isolated and that effectively they've not transitioned to adult life. In other words, they become stuck. Many of these individuals won't have a job. Because of that, they're spending far too much time engaged in repetitive activities. The nature of repetitive activities is very sensitive to whatever is dominant in that society at that particular point in time. So the fact it happens to be video games or computer games at the moment doesn't mean that would be a common interest in 20 years' time when things have moved on. And often everybody else is complaining that the individual is difficult, that they might be rigid, and particularly important, that they might not show the initiative that you would expect given their level of intelligence. And this is a severe problem for people with ASD who go into higher education, that very often they may be the smartest person on the course, but find it hard to motivate themselves or to know what to do to make things happen. And because they're smart, people underestimate the amount of guidance that they might need to know what their strengths are and how they should be moving through university and what sort of jobs they should be thinking about doing afterwards. But even in less able people, the lack of initiative is a common complaint from other family members. Now, if someone pitches up in your surgery or you come across someone elsewhere, what are the warning signs that should have you thinking that you should be moving on to a developmental history? Well, people with ASD sometimes do markedly avoid eye contact. So I saw a woman, age about 25, last week for a first diagnosis who works in a retail setting, is an assistant manager in her department, and didn't look at me once in an hour and a half. Her parents were there with her, and what her parents report is that when she appears to be looking at them, actually she's looking at some point in between her eyes. So she finds eye contact physically aversive. It generates an extremely uncomfortable feeling in her. Equally, I will see patients who might look at me too long. They're holding my eye gaze, and it's not that they think I'm handsome either. They are holding eye gaze too long because they don't know intuitively what is the right amount to indicate either interest or a change of conversational topic. So one can't make a diagnosis or be animated simply by amount. It has to be how the person uses the eye contact they've got. Another good clue is lack of social smiling. So most of us, and indeed most primates, when they approach a co-specific, will smile in greeting. And it's quite hard, actually, not to return a smile if someone smiles at you. But people with ASD will find that naturally difficult. And usually, although people might have some facial expressions, it's not uncommon to notice that for a lot of the time the person's expression is more fixed than we would see in the general population. So over coffee or lunch, scrutinize without making it too obvious the faces of people you're chatting with and look at what the muscles of their face are doing when they're not engaged in a big recognizable expression. Most of us have tiny movements in our facial muscles that reflect what we're thinking or feeling, which is why we have the expression poker face, because poker players have to learn to disguise those very tiny movements. And most people with ASD lack that moment-to-moment variation, which is what gives them this, or can give people, an apparently blank facial expression. And that can mean in the setting of having some clear smiles or looking sad or angry. Quite often, eye contact, verbalization, facial expression are not meshed together in the way that they would be in the typically developing population, and people may rely unusually on either, and most commonly, verbal interaction or using eye contact too much. If you're doing an ADOS with someone, you're paying particular attention to whether the person is enjoying the interaction. Less easy to set that up in an everyday situation, but I try my best to make some very bad jokes or tease people and see if I can engage people in some humorous interchange or not, because I want to know whether people are able to react spontaneously to any emotional signals that I'm giving out. And particularly importantly, when it comes to dealing with comorbid disorders and recognizing them, people with ASD are very impaired at recognizing their own emotional states and being able to describe them to other people. And so it's not unusual for relatives to describe that someone seems to suddenly have an outburst for no apparent reason. When you dig down, what has usually happened is that the individual has been put in a situation that has made them anxious. They show no outward signs of being anxious. They don't understand the physiological symptoms they're having as being anxious, and eventually they're so overwhelmed by anxiety they get cross or leave or throw something. So it's very important not to take lack of facial expression as signifying that nothing is going on inside. And in fact, a key aspect of management can be helping people to recognize how to interpret their emotional states, so that they know how to react appropriately. We know that people with ASD will have more trouble than usual in being empathetic or showing insight into social behaviours, and very often parents will complain about lack of responsibility, that they have an adult offspring who should be doing all sorts of things that would be age appropriate, and they're not. Social overtures may be very thin or weak. It's not unusual for me to stick out my hand to shake a patient's hand and it be totally ignored, or for people just to get up and leave my office. I mean, when they're meant to, but without saying goodbye or with any other leaving behaviour. So some of these things you're more likely to pick up in the waiting room when you go to meet a patient than you are once you're in an interaction. And part of the difficulty that we have in making diagnosis in the usual clinic setting is that we're there asking a string of questions, which is not how you're going to pick up ASD, because the person's probably going to be able to answer the questions perfectly well. Of course, if you ask the right questions, you might elicit a history of what's going on in the broader social world. But if you really want to find out what's going on, you have to engage in some reciprocal social communication with the person, which usually means revealing something about yourself. It doesn't need to be the status of your bank balance or your love life. It could be the traffic jam on the way into work in the morning, or something you saw in the paper. But reciprocal communication is not either asking people questions or telling them things. It's a conversation where we're offering information and wanting something to come back. And that usually requires people who are trained diagnosticians to adopt a slightly different style. Of course, we are well trained and knowing what sort of level of rapport we've established with people. But we need to be aware that the rapport isn't actually indexing what a good clinician we are. So people who see kids with autism know very well that they might see a child for diagnosis who performs flawlessly with the consultant, all sociable, does everything, and the parents are watching through the one-way screen, horrified that this clinician has got this child interacting and talking. And then the wise clinician goes off to the school and observes the child in the classroom or the playground and sees something completely different. And that's because individuals with ASD, and although this applies more to children than adults, it also applies to adults, will be at their best in a one-to-one interaction with an adult. And in part, that's because typically developing adults will not let people hang out to dry. So if there's a break in the conversation, we will step in and patch it or repair it. And so if one's trying to make an assessment of ASD, you have to be very wary that you're not disguising the person's difficulties by not letting them flounder. Stereotyped language can take many different forms. In its sort of mildest form, it can simply be repetition of single words. When I'm doing ASDs, I will occasionally write down that someone has had the same beginning to a sentence 10 times. When I've written it down 10 times, I stop writing it down because I've sort of proven my point. Or they might have a longer phrase that is repeated. Or you might pick up something that sounds as though it would be appropriate for a civil servant or an academic, but not somebody with that cultural background to say. Or you hear something sounds like it was from their parents' generation, or something that you recognize as coming from TV or radio. So stereotyped utterances can take many forms, and one of the most useful clues is to see people twice and hear the same language verbatim the second time. There's really no other disorder where one is faced with that sort of situation. By and large, the most able adults don't usually ask inappropriate questions or statements of doctors. So the person who asks you your date of birth and then tells you what day of the week you were born on is uncommon. Does happen, but it seems a shame to take the money just on the basis of that one question. So I've talked about difficulties in conversation. So conversation is something where one of us introduces a topic and the two people in the conversation, or more people, have no idea where it's going to go next, because we're saying something that's a response and also an opener for the person to say something back to us. People with ASD will have more difficulty than typically developing people doing that. They might be able to keep up a few conversational turns, but often things will die after a while. Or if they're smart and have learned alternative strategies, they might steer the topic onto something of interest to themselves, which would enable them to keep going. Social chat isn't conversation. Social chat is what you do at the bus stop or on the train or in the checkout queue. Usually involves making some inane comment about something that's blindingly obvious, like bad weather today. You know, in England we talk about the weather the whole time. And the purpose of social chat isn't to convey information. If you're standing in the rain, you know the weather is bad. So social chat is designed to oil social wheels and make some sort of link with people. And individuals with ASD, many of them wonder why the rest of us do it, because of course it isn't strictly logical in terms of conveying information. And many people learn they have to learn how to do it, particularly in work situations, if they're not going to stand out as being unusual. And so both of these are abnormalities that can be difficult to pick up in a typical clinic setting unless you go out of your way to be rather more sociable and effusive perhaps than you would be usually with a patient. Prosody refers to how people say things. In 30 seconds you're going to hold up one of those cards. And so this can be a useful diagnostic sign. We're used to people with autism perhaps having a voice that is reduced in variation, at its most extreme being monotone. But speaking too softly so that it's hard for other people to understand, or too loudly, are prosodic abnormalities, or getting so excited that you start to run words together because you're speaking too quickly is another one. Or you might hear a stress pattern that is the same across multiple different sentences. In other words, it's as though there is a tune underlying the sentence that is constantly repeated. By and large, people with ASD are better at offering information about themselves than picking up on things that you might offer about yourself. So, for instance, in the ADOS, the examiner is meant to repeatedly offer minor bits of information about themselves to see what the child or adult does. And in my experience, quite often one has to up the level of excitement of what you're saying until the person will eventually respond. Circumscribed interests usually will not pick up unless you ask about them or relatives tell you about them, and you should become suspicious of any big collection or an unusual wealth of information about a topic that is separated from belonging to a club or sharing it with other people or doing something useful with it. Families will often complain about resistance to change and people having very stuck routines. We've already covered this. So those are all things you might pick up when someone comes to you, possibly about something else. And if you're suspicious, the next thing to do is to take a developmental history. And the reason you're taking a developmental history is that able individuals will find ways of bootstrapping around their difficulties so that they're not as obvious in teenage years or adult life as they would have been when the child was much younger and hadn't learnt to do these things. As I pointed out, some behaviours people just grow out of, particularly some of the more obvious repetitive behaviours that can be useful diagnostically. And sometimes the environmental press for giving things to people, sharing things we expect in young children is no longer relevant in older children. And of course, if people have other difficulties, then that can just complicate the picture terribly. If you're depressed and not doing very much, then how do we judge the quality of what you're doing if there isn't a lot of it? So when we go back in time, we tend to focus a lot on joint attention behaviours. So that's requesting, giving, showing, taking, bringing things to your parents to show them what you've done either just then or at school, imitating parental activities or idiosyncrasies, waving goodbye, very common for parents to have spent a lot of time teaching kids with ASD to do that. Not being interested in children you don't know. Most typically developing kids, if they're not shy, you take them to a park or on a beach. It's not long before they're in with other kids, children with ASD, sometimes very disinterested or might just watch and not engage, and might react negatively to the approaches of other people and not wish to participate in interactions. And of course, the friendships, if they develop them, may be more limited in scope than we're used to seeing. By and large, able adults do not have a history of language delay, because otherwise they would have been picked up early in life. So the group we're picking up as adults are those who historically might have been given a diagnosis of Asperger's syndrome. But people with Asperger's can echo when they're kids. The stereotype language might have been much more obvious and form a greater proportion of what people say when they're younger. And sometimes people may have had verbal rituals when they're younger. And particularly important is finding out about people's imaginative play. What did they do with dolls, cars, buildings, symbolic toys? Did they play symbolically with them? And if they did, how much did the play vary from day to day? Or was it always the same storyline? Or did it vary, but it was driven by what was on the episode of their favourite TV programme the night before? It's not unusual for a child to do an ADOS and produce a brilliant bit of pretend play, only for the parents to tell me afterwards that they'd seen it the night before on some particular TV show. Sensory interests don't often make themselves apparent in a clinical setting, but the DSM-5 has included sensory sensitivities within the diagnostic criteria for the first time. Most commonly, this would be oversensitivity to noise. And so, again, if you take a developmental history, it might be that the child would have covered their ears with their hands in response to motorbikes or trucks going by. Adult patients who have this will sometimes describe it as physically painful. So I have one patient who described it as someone sticking pins in her. So these are genuine hyperacusis. And if you do see any hand and finger mannerisms, they might not always be full-blown sort of complicated things that we're used to. They might be more subtle dystonic posturing. Now, what DSM-5 has done is collapse autism, atypical autism, PDD, NOS, and Asperger's syndrome into one disorder, autism spectrum disorder, which makes a lot of sense. It makes sense from an etiological point of view, because if one looks at families that have two or more individuals with autism in the family, one can see every combination of those four diagnoses. So these previous diagnostic categories were not breeding true across the whole spectrum. One will, of course, see some families where you only ever see Asperger's, or other families where one only ever sees autism, but many families where one sees people who are both very handicapped and very smart in the same family, and they clearly have the same disorder. So this is a big plus, I think, to unify this. And in the past, certainly in the UK, you would only get extra help at school if you had a diagnosis of autism. If you had atypical autism, that didn't count. So this is a big plus. Most people with Asperger's syndrome will meet criteria for autism. There was a lot of debate in the past about whether we should have given them a label of autism or Asperger's. So I don't think it's a significant worry that people with Asperger's are being disenfranchised. Most of them will meet ADI criteria. But able adults with ASD, particularly the smart ones, often do not meet the thresholds on the ADOS. And by and large, that's because they've acquired compensatory strategies. And for research purposes, most journals are happy to accept that the ADOS has been done as a way of making sure we haven't got it totally wrong, but most journals would not require people meeting both ADI and ADOS criteria to be included in the study if they were an able adult. It's good to hang on to the concept of a multi-axial diagnosis because it reminds us to ask about other domains, particularly IQ and people's language abilities, and identifying other medical disorders is particularly helpful because people with ASD are not very good by and large at looking after themselves, and therefore knowing if they've got something else is important. I occasionally see adult psychiatrists give someone who's already got a diagnosis of Asperger's syndrome another personality disorder diagnosis on top, or sometimes several additional personality disorders. I would caution against that because people with ASD can do some very strange things. And most of us who are used to seeing people with ASD have a very wide tolerance for a lot of things coming under the diagnosis of ASD. And if, for instance, someone gets an additional diagnosis of borderline personality disorder, I think that's tantamount to saying they're a difficult person and we'd rather shove them off somewhere else, and could someone else look after them, please? So I think ASD is quite a disorder in its own right without having to invoke other personality disorders. The same logic does not apply to anxiety, depression, OCD. So these are the comorbid disorders that one commonly sees. You're going to hear a lot more about these in the rest of the day. Eating disorders is the big surprise, in that it turns out that about 30% of girls and women with eating disorders have ASD that has usually not previously been diagnosed, which is probably going to mean we need to reconsider some of the older literature on family characteristics in eating disorders, because it might be that what people were picking up were autism-related traits. Psychosis, more often than not, is stress-induced psychosis because someone has been very anxious for a very long time, but occasionally people do have schizophrenia, and a small proportion of people will offend, but there's no particular type of offence. I'm not going to run through these because they're in your handout. There is really no good data on whether or not we should be doing genetic testing in individuals with ASD with an IQ above 70. I don't routinely. If someone is dysmorphic in any way or the clinical picture is unusual, then I do. But that's a sort of common sense judgment, not based on evidence. There's only one specific gene that's been picked up that is worth testing for, and that's something called P10, which is a proto-oncogene. And if you have someone with a head circumference 3 standard deviations above the norm, then you should test for this gene, because about 2% of those people will have a mutation in it, and it's associated with an increased risk of cancer. It's familial, and other relatives may also need to be tested as well. I would love to have psychometric testing on my patients, but maybe, well, if I go to heaven, then it might happen. So, final couple of slides. Very important to have a long-term plan. We can get overwhelmed with dealing with anxiety, suicidal thoughts, severe OCD. We have to deal with all of these things, but we've also got to get the person's life kick-started again. And I think the art here is to generate the impression of momentum where none currently exists. And by that I mean this is old-fashioned psychiatry, where you have to engage with the patient and the family and really instill some hope in them that you've got the capacity to make things happen over time. On the downside, I'm realistic and say it will normally take 4 or 5 years for me to get that person back into society, into a job, and functioning in a way comparable with their peers. But I think people have to know that it can happen if you've got the will to make it happen. And in the longer term, I think it's better to anticipate problems, particularly if people are going into employment or into higher education or leaving the parental home, rather than responding after they've happened. And I like to see my patients fairly regularly, so I know what's going on and I can head off problems before they develop. And in terms of the broader issues, here we have a disorder that affects 1% of the population. It would be strange if adult psychiatrists couldn't diagnose the other disorder that affects 1% of the population. But for historical accident, we're in a situation where adult psychiatrists, by and large, are not feeling as comfortable about diagnosing ASD as they are schizophrenia. And so this has to become a mainstream disorder so that family doctors, as well as adult psychiatrists, feel as comfortable in the diagnosis and managing of ASD as they do much more common disorders, or equally common disorders. And that's an educational challenge. I think if we can achieve that, then support services will come into play. Most higher education establishments have disability services very patchy in terms of their level of expertise of dealing with autism, and I would strongly encourage you, any of you that have links with universities, to force yourself upon these disability offices and help support them in managing people with ASD. I spend a lot of my time chastising job agencies and job coaches to do more and do it faster and to be ambitious for individuals. I don't think any of the people in this room would be happy for their entire life working in a warehouse or filing or doing many of the menial jobs that often people with ASD are put into to sort of keep them out of harm's way. And this requires identifying people's strengths. From a diagnostic perspective, of course, we're focusing on people's weaknesses, but I have a collection of patients at the moment, 5 of whom are sufficiently skilled artists I'd spend thousands of dollars on their work. And I have other people who are skilled in other areas. So many of these people have lots to offer to society and to employers. And the challenge is how to turn those skills into something that will be employable. Because parents have been preoccupied with helping a child get through school, often these individuals are not as skilled in self-help skills as they might be. And usually there has to be a focus on teaching people to cook and shop and use the washing machine. And sometimes people are not very good at travelling independently either. And being able to travel independently, and if possible, getting a driving license, opens up many more job opportunities for people. Eventually, of course, parents are going to die, and unless we want SIBs or other family members to be looking after people as they get older, then we need to make sure that people learn the skills to live independently. But we don't want people independent and totally socially isolated. We're just about to set up a scheme in Vancouver, a so-called befriending scheme, where we will ask members of the general population to see someone who's socially isolated with ASD once a week or once a fortnight and do things with them. So it's very important that people feel that they're being integrated into society. And actually, if we can put all of these things in place, the rate of psychiatric comorbidity drops rather astonishingly. I'm going to stop there because I've overrun, and I appreciate the fact you didn't flash those dreadful cards at me, but we've got some time for questions. Thank you.